Okay, good afternoon, everybody, and a very, very warm welcome to this afternoon's session, Beyond the Student Mental Health Crisis, where we will be having a very lively and timely discussion. So I'm going to say a couple of very, very minor housekeeping points, and then I'm going to hand over to our official welcome host. So we're going to have the chat function open today. We won't be monitoring it and using it to respond to questions, but we are really, really interested to hear your thoughts and your observations and your comments. So if you could please kind of share your responses in the chat, but just note we won't be able to monitor it and answer any particular questions right now. So I am very, very pleased to be introducing. So Tim Hitchens is opening the event for us today. Tim has a long history of public service through the diplomatic service and joined the University of Oxford in 2018 and is the president of Wolfson College, which is one of our graduate colleges. And he's been leading the sort of strategic work at the university, and he chairs our Student Mental Health Committee. So Tim, I'm going to hand over to you to officially welcome everyone to today's session.
Thank you very much, Jane, and my warm thanks to everyone who's come together today, stateside and here in Europe, to hold this half day of conversation. And my thanks in particular to the organisers of the event, which I hope will be part of a series of discussions about how best to help young people whose healthy development is at the heart of our professional lives. As Jane said, I'm Tim Hitchens, and unlike most of you, I think I'm not a mental health professional. For over 30 years, I worked for the British government as a diplomat and as an ambassador. And then since 2018, I've been the president of one of Oxford's remarkable colleges, which provide a home and a community for our student body. And my own college, Wolfson, exclusively looks after graduate students, 80% of whom are international. It's a little known fact that Oxford has more graduate students than undergraduate students, and they bring with them a mindset and an approach to learning which is naturally different from that of a British 18-year-old arriving at university for the first time. And as Jane said, I also chair the university's Committee on Student Mental Health. Well, on both sides of the Atlantic, there has over the last 20 years been a tectonic shift in attitudes towards mental health. What used to be unsayable is now often said, and we have collectively, given our populations, old and young, across the genders, permission to talk about what worries and distresses them, and that is a great step forward. But increasingly, it seems that this permission may have had the unintended consequence of turning people's perceptions of healthy emotional responses to normal, difficult life events into something which is perceived as abnormal, a fear of falling helplessly into a mental health disorder. So the challenge of this decade is to focus our limited and precious resources, people like you with your tight and tightening budgets, on those who need it most, while giving agency to other people to be at home with their own entirely normal insecurities and worries. And for young people especially, and that's who we are today focused on, education, including health education, is at the heart of our responsibility. Well, in particular for our US colleagues, let me give a short introduction to the situation among young people in Britain. We do tend to follow you to good and to bad effect. So demand for mental health services here continues to rise sharply across the education sector. 57% of our students say they have a mental health issue. Between 2017 and 2022, the National Health Service, the NHS, reports rates of probable mental health disorder among 17 to 19-year-olds rising from 10 to 25%. The number of children and adolescents in contact with mental health services over that same period has grown by 200%. And those in their early 20s, who are economically inactive, to use the technical term, are now more likely to be workless due to ill health than those in their early 40s, with mental health the leading cause. Set against that, the number of those seeking mental health treatment has grown at a faster rate than the number of those with a mental illness. The levels of serious psychiatric disorder remain relatively stable at 1 to 5% of the population. The figures at Oxford for those who seek mental health support annually, 13% of our students, and or are registered with our Disability Advisory Service, 27%, they have stayed stable for some years. And the over-medicalisation of distress and the pathologising of appropriate emotional responses to normal life events is now well evidenced. And these trends are, I think, broadly consistent across Europe and North America. Why is this happening? Well, there are some real deep-seated causes. We are improving our understanding of the psychological impact of adverse childhood experiences. Societal inequality, increased academic pressures, and reductions in unsupervised childhood play are relevant. We're understanding better the way neurodivergent conditions in girls and women are expressed. And population-level increases in demand for statutory clinical services is placing unsustainable demands on the NHS. In response, there has, since at least 2009, been an intensification of government engagement with this challenge and in expectations placed upon higher education institutions. Helpfully, collaboration between those institutions is probably better now than it ever has been. Both main political parties in the UK are similarly focused on this issue. And the number of schools with counsellors, I found this an extraordinary statistic, has risen from 36% in 2016 to 73% last year. But we have to be honest and say there have also been responses which have been unhelpful. An anxiety for student safety appears to have prompted an increasingly paternalistic and protectionist cultural turn in sector policy and guidance. The boundaries of responsibility between higher education institutions, students themselves, and external services are often unclear. Higher education institutions are sometimes reluctant to manage risks and opt instead for minimizing them, and that is part of that paternalistic pattern. And the distinction between student demand and student need is not always clearly drawn. Well, as part of the Oxford Student Mental Health Committee, we've been tackling issues which I'm sure many of you too will be sharing. As a very complex organisation here in Oxford, with a central administration, over 35 independent colleges like mine, and academic divisions, which can feel like universities in their own right, all trying to support almost 30,000 students, the scope for crossed wires and a misunderstanding of roles is ever present. We have, after much consultation across the whole university and the local National Health Service, created what we called a common approach, which sets out who does what students can expect, and some basic principles, such as the limits of reasonable provision and what we call 4 layers of mental health support. And we're also looking at how to identify more quickly those individuals who need rapid and personalised support from among the many students with more conventional exam anxiety or relationship worries. But that said, it often feels as if we are struggling to keep up with the range of challenges facing us, most importantly from the student experience, but also from government and from regulators. So let me quickly summarise a number of issues across the sector which are relevant to us here today. First, how to differentiate those students with serious psychiatric disorders from those with normal anxiety, and what level of resource to place on each category. How do we best place students themselves at the centre of this discussion, giving them agency and responsibility and helping them to overcome life's setbacks? How do we ensure the lines of responsibility between individuals, universities, and the National Health Service are drawn clearly, while recognising, of course, that their roles are a continuum? And finally, how do universities build the best partnerships with our health services? And for those like Oxford, lucky enough to have major research strength, how do our departments of psychiatry, clinical and experimental psychology collaborate best with student support services? So I look forward to hearing your thoughts on this today. I do think a consensus is building across the Atlantic, and today will be part of that. And I hope that the second part of this conference on, I think, the 25th of March will be part of a tectonic shift as significant as that 20 years ago, which brought the stigma over mental health to an end. So that's me. It's now my great pleasure to introduce our first professional speaker, Ben Locke. Dr. Locke is a licensed psychologist and Chief Clinical Officer for Togetherall, a clinically moderated peer support platform available, as you'll know, to millions of people globally. Ben has worked in the mental health field since 1995 in a wide variety of settings, including more than 20 years in college and university counselling centres, with a focus on administration, operations, and research. And prior to joining Togetherall, Ben served as the Senior Director of Counselling and Psychological Services at Penn State University, where he was also the founder and the Executive Director of the Centre for Collegiate Mental Health from 2004 to 2021, and an affiliate faculty member in both the Counselling and Clinical Psychology departments at Penn State University. So Ben, good morning to you across the Atlantic, and welcome. The floor is yours.
Oh, thank you very much. And as it so happens, thank you for that kind introduction and your words of framing and direction for us today, I think are right on the mark. As it so happens, I'm actually in London. So I'm right about tea time, I think, here. Let's see if I can share my screen successfully here. Is that coming across okay? Somebody coming across okay? Very well. Well, thank you again for the introduction. I'm honored to be part of this program today. This crisis narrative critical examination has become a real soapbox for me and an area of passion starting in about 2015. I'm going to provide about 30 minutes of comments today, and with luck, we will have about 10 minutes of break after my comments before we go on. We'll see how long I carry on for. And as I've reflected a little bit on preparing this talk and a series of talks that I've done around this, I'm just very acutely aware of the passage of time. And 2025 will mark 30 years for me in the mental health field in one form or another. And if one thing is clear, it is that change is the only constant. And as has already been alluded to today, change is what's coming for us in the future, because where we are now in terms of our conceptualization of mental health is not tenable. I'm going to try to just tell a story of what I have seen in an arc of time from clinical, administrative, research, technology perspectives, but especially as the privilege of having 17 years of my life building the Center for Collegiate Mental Health with hundreds and hundreds of college and university counseling centers, and trying to tell their story and the story of their staff and the story of the students they serve. When we think about a crisis, it feels really important to note that crises are supposed to be passing. They're supposed to occur and be intervened with and resolved. That we have been in this constant state of perceived crisis for nearly 2 decades is really untenable. And so our job today, my job in this next bit, is to try to walk you through some of the ingredients of the crisis narrative all around us, with the goal of coming together in new awareness, articulating the dynamics that swirl around our day-to-day work so that you can see them and hear them and act on them in new ways. This is just a first step in that process. All right, let's see if I can advance the slide. So really important just to say the crisis narrative of mental health is a current dominant social narrative. It wasn't always, it will not always be. All cultural narratives change over time. What's really important that I want to drive home here is when you hear the phrase, the crisis or the mental health crisis, recognize the meaninglessness of that phrase. It's just a shorthand reference to books and books and books of dynamics that are too complex to explain. And the problem with it as a phrase is it just creates urgency. There's no detail. There's no specifics, and we'll unpack that here as we go. Our context today is at the macro level of society, of culture. We are not in any way questioning the experience of an individual person and their experience of crisis or a symptom. And we absolutely know that people are experiencing very real mental health concerns. And the providers in college and university settings are absolutely coping with very serious situations on a day-to-day basis. And it is also true, as we'll see, that the macro system dynamics of society and the narratives that exist ripple down through the layers, and they have a direct impact on the individual that we have, I think, only really begun to understand. So that is our context for today. And in terms of why we need to have this conversation, this is one of my all-time favorite slides. This was from a Time magazine article in about 2022, illustrating the change, the growth in the percentage of people receiving mental health treatment, up about 33%, versus the drop in the percentage of people reporting they have excellent mental health, dropping about 21%. These just don't make any sense when they're plotted next to each other, when they're juxtaposed like this. And it should create real urgency for everybody designing mental health interventions, trying to grow mental health interventions. If this is the outcome, then we're doing something fundamentally wrong, and we can't just do more of the same. This is why we need to have this conversation. If you need another motivation, ask yourself this: when will the crisis be fixed? In your world, in your zone of work, how will you know when it's over? Will it be when you treat 4.5% to 5% of the population with serious mental illness, a very stable figure for about 50 years? Is it the average percentage of students in a university treated in the counseling center, let's say 10 to 12%? Is it the percentage of students who screen positive to a mental health concern, which is 50 to 60%? Is that when we have tipped over and solved the crisis? Or is it when we treat 100% of the population because everybody can benefit from a mental health support service? How do you know when you cross the line, when we fix the crisis? The fact that we don't know this answer and nobody has been speaking to it should be cause for concern. So what we're going to do, or what I'm going to do here in this next bit, is walk through 6 elements of what I say are contributors to the crisis narrative that we're all experiencing. And then I have a couple of examples at the end. All right. So our first example here, our first ingredient is advocacy. And it just feels important to say right off the bat that advocacy is happening at every level of society, and it has done incredibly good things for people with mental health concerns. If, think back to 100 years ago, how folks with mental illness were treated. Whether it's a student or student group doing the advocacy, whether it's a provider or an administrator, if it's a foundation or charity, a state or provincial government or legislators, or a federal government level advocacy or funding, all of these groups can advocate, and all of them have created or contributed to new and different kinds of interventions. But these things have a couple of things. All of these different types of advocacy have some things in common. They're all well-intended. Nobody's trying to do a bad thing here, number one. Number two, they're totally uncoordinated. Nobody is trying to get all these to move in the same direction. There's no common definition for what it is that we're advocating for, and there's no goal. If you were a foundation advocating to end polio, you'd have a very specific goal, and when you got there, it would be the end of your foundation. What we find today is, because there's no clear endpoint or goal, advocacy groups tend to broaden and continue to exist year after year in order to stay relevant, in order to pay the bills. And they become self-fulfilling and self-sustaining efforts. Again, all of these are well-intended, but with no clear shared definition and no clear goal that we're aiming for, they're kind of moving us in all different directions. And a couple of outcomes that have occurred across the board is we have dramatically increased the rate at which we identify people with mental health concerns and refer them into professional treatment systems that do not have the capacity to absorb them. And because of that, we have this constant sense of crisis, which is actually a crisis of capacity. So in the advocacy and intervention space, a lot of good work, but the lack of clear goals and a sense of progress is really getting in the way. And directly contributing to this idea that we're in a constant state of crisis. So the next piece I want to speak to is this idea of normative human experience becoming pathological. Zooming way out from our day-to-day work in mental health and just thinking about the human being for a moment. Humans are walking, talking, breathing feedback mechanisms, biological feedback mechanisms, both within ourselves and between each other. These feedback mechanisms evolved over millions of years, and they include things like the experience of pain, the experience of anxiety and worry, distress in general, sadness, worry for others, worry for myself, the experience of grief, the experience of shame, jealousy, anger. These are universal normative human experiences. And these have become the symptoms of disorders. They don't define disorders in and of themselves, but they are part of most diagnostic systems. And this is really a multi-threaded path that includes the expansion of the DSM, beginning with the DSM-3, 4, and 5. It includes dynamics such as who pays for treatment if you don't have a diagnosis, and providers trying to treat people who they see are in distress, and so on and so forth. But when we think about this, this expansion of diagnostic systems, including normative human experiences, has been absorbed into media, social media, as we'll talk about in a little bit, and our modern identities of who we are. This has been absorbed from the culture down to the individual, and is now helping to drive people's identities. Anybody who's a parent, a student at any level of secondary education or college has seen this in either your children or in their peers. All right, so looking at research, this is a favorite area of mine over many years, doing a lot of different kinds of research. But research moved from being very, very, very difficult to do to being democratized in the online survey. Anybody, anywhere can do a survey and create beautiful charts. They can do it really quickly. You can do it in the palm of your hand. And there is this corresponding loss of rigor and fidelity around the methodology that's used. Key problems like non-response bias, self-report only data are routinely ignored as surveys are discussed and presented out in the world. And surveys are self-report only, so they of course reflect the dominant social narrative of society when people respond. And as we'll see in a moment, as survey results and research results are sort of work their way through media and social media, results are just interpreted as facts, limitations are ignored, and you end up in a self-reinforcing cycle where people who produce crisis results are much more likely to be attended to, receive funding, and receive more attention. And over the decade and a half or so of building the Center for Collegiate Mental Health, I can't tell you how many times I spoke with a reporter who said, well, that's not a very interesting finding. Don't you have anything that's juicier than that we can report on? And that's really part of the problem, is that research that represents crisis gets attention and that which doesn't, does not. That's so important part of what we're doing here today, is to talk about some of the research that's coming out in this area. Okay, so moving on to media and social media. This could easily be an hour-long conversation, but to say this in very briefly, media has moved from a subscription-based model to a pay-per-click ad revenue model. The news cycle is incredibly fast, incredibly shallow, headline-driven, and if it bleeds, it leads. And we see this again and again and again in mental health. And very frequently, the real details that matter are way down in the article or not included at all. It doesn't mean there isn't good media reporting being done. It just means that the bulk of the flow of information has these characteristics. Part of the reason that this happened for media is, of course, the rise of social media, which has now supplanted media as a key distributor of information. So social media, just to frame it, is a multi-billion-dollar, gazillion-dollar industry that revolves around your attention. It's an attention economy, and there's a huge range of people out there disseminating information, totally accurate and useful and important and helpful, completely misleading and misinformation, and then somewhere in the middle, a whole variety of people trying to influence each other. And in the mental health space, the social media is full of people trying to influence around mental health, and much of it is wrong or misleading or not completely right. Even the slightest dive into psychological research about how people's thinking and behavior can be changed, the smallest amount of stimuli, it's right there. So if you just do a quick dive, you'll immediately see that we can change people's thinking and behavior with just a priming stimuli. Think about the impact of growing up in a social media environment and being bombarded for a decade with information. We have seen this play out in elections. We've seen it play out in sort of general social behavior. We're absolutely seeing it play out in social media and mental health. So this is a key contributor to both of these are key contributors to the crisis narrative. So moving along to industry, the mental health marketplace has been around for a long time. You don't have to look much farther than your pill cabinet or pill bottle to know that the pharmaceutical industry has been driving this for a long time. There was a real quickening, though, around 2014 when the crisis narrative really began to take hold, and people were attracted because they think there's a crisis and we need to come in and try to fix it. And perhaps there's money to be made there as well. So in 2021, it's estimated that about $5.5 billion were invested in digital mental health. Each of those investors is seeking a return on those funds. And the crisis narrative, the mental health crisis, is constantly used in the sale of goods and services in the mental health space. It's actually one of the first things I did arriving at Togetherall to say, we're not doing this ever, because that's not what we're about. But it is something that is everywhere throughout the industry. And a key contributor to the crisis narrative. It's used because it's effective. It works. It creates urgency without detail in the sense that you need to do something quickly to respond. Okay. Language and subjectivity. The modern information age means that everybody holds in the palm of their hand the world of information. And if you want to understand quantum mechanics, it's right there. If you want to learn how to do open heart surgery or fix almost anything on your car, it's right there on your phone. And the same is true for mental health and psychology. So when we think about 20, 30 years ago, highly professional jargon in the psychological industry was in books, and it was in the offices of professionals who were doing evaluation. All of these terms, going back to sort of Girl Interrupted as a book in the mid-90s and a movie in the late 90s, began to move this information and these terms from the professional's office into the mainstream culture. And society has gradually soaked up all of this specialized jargon. And now we're hearing it coming back through the general population. In a way, we have convinced a generation or two of people to use this highly professional, specific jargon language to describe their internal subjective experience. And the bind is that this language was created for very specific professional purposes, has very specific professional definitions, is now being used by everybody to describe incredibly variable internal subjective experiences. So we've been incredibly successful on the one hand at decreasing stigma and encouraging people to come forward and to use this language of anxiety, depression, and suicidality to talk about themselves. But the problem we've created is that there's a big divide in the language used and the meaning that actually exists. And I know firsthand from a lot of people struggling with serious mental health concerns who cannot get access to treatment are very frustrated by this idea that anybody who says I have a mental health concern is treated equally somehow, when in fact there's huge differences in severity and need. So that covers sort of the six of the, let's say, of the ingredients of the crisis narrative that are out there. I want to talk for a couple of minutes of a couple of examples. And I actually had quite a lot of these and ended up cutting most of them because there just wasn't time in a half an hour. But I'm going to give you a couple just to look at, and I have a couple of ideas for you moving forward from today. So this is an example that threads together the advocacy concept, the surveyification research concept, and then media, and of course, social media. So in the US, there's a foundation called the Kaiser Family Foundation. They commissioned a survey called the Mental Health in America Survey. CNN was a partner in this survey, and it's actually an opinion poll if you look behind the scenes. Covered a number of different topics. One of them was this question: in the US today, is mental health a crisis, a problem but not a crisis, or not a problem at all? Now, if I had proposed this for my dissertation, I probably would have failed out of graduate school and probably any methodology class. But this was one of the questions that was asked, and the result was 90% of US adults say mental health is a crisis. And note, this is an opinion. It has absolutely nothing to do with symptoms, prevalence, personal experience, anything. It's purely an opinion. And the methodology and the sampling behind this is really, really not good. I'll leave it there and you can go dig it up if you want to look at it. This is how that result was presented in CNN. And the opening paragraph says, an overwhelming majority of people think the country is experiencing a mental health crisis. Mind you, there were 2,000 people who responded to this, who either answered a random piece of mail that came in their mailbox or had a prepaid mobile phone plan, and they answered a random phone call too. So those 2,000 people became an overwhelming majority of people in the country. This article is juxtaposed with a life or death title of the mental health crisis among teens. It's a New York Times article. And again, there is no data here about underlying mental health concerns, prevalence, diagnosis, symptoms, experience, anything, purely an opinion. Here's another example. If you haven't dug into this one, the spread of the spread of Tourette's through TikTok, this is a great article to look up in Psychology Today. And it was a case of young girls and young women appearing in emergency rooms with really disturbing tics, that verbal and motor tics that seem to have come out of nowhere. They were traced back to an influencer on TikTok. And this should not be a surprise because the concept of conversion disorder, of mass psychogenic illness has been documented for generations. And of course, we know that suicide contagion is real, and media, have guidelines around reporting on suicide to avoid that contagion. So the question we need to ask ourselves when we think about these is, do we believe that mental health contagion is entirely limited to highly visible, disruptive forms of mental health? Or does it seem more reasonable that contagion is impacting people in ways we don't see, where it's internalized, affecting their identities, affecting their experiences of depression or anxiety or those kinds of things? Of course it is. And as I mentioned before, what we know about impacting people's behavior and thinking is very easy to do. So this is a really powerful example of a very specific example of how social media can have this impact. One final example here, and then I'll touch on a couple of take-home points, hopefully, that you can take with you, and we'll have a brief break. The Center for Collegiate Mental Health puts out a report every year. It summarizes a lot of data, and there's two of my favorite data points, which we used to report on every year, which was the perspective of clinicians who met with students on whether or not those students had suicidality as a presenting concern, and the self-report of students coming into the center indicating whether or not they've had thoughts of ending their life. This is a best case scenario to look at the role of self-reported bias in surveys, because in this data set, essentially 100% of each center is reporting data out, as opposed to a sample or a sample response of, let's say, 9 or 10%. So when we look at clinicians, they would say about 8.3% of students present with suicidality as a presenting concern of some kind. That's after some sort of an evaluation. And that tracks about right for folks who work in college and university counseling centers. Now, if we look at students who come in and complete their intake paperwork and indicate they have thoughts of ending their life, we see 36%. The 36% is what you would see reported in media and social media. And the key thing to understand here is that this represents, depending on which data point you present, a 432% increase in prevalence, if you want to call it that. Now, if we only ever rely on self-report surveys with a non-response bias, this 400% increase is a best case scenario. Imagine if you're only getting people to respond to surveys who are motivated and most people aren't responding at all. It, of course, also reflects the role of language and subjectivity, where professionals are talking about one thing when they mean suicidal ideation, and people very commonly apparently have thoughts of ending their life or don't fully understand the question. So this example really underscores the importance of getting data from multiple places and tracking that data over time. Okay, I think I've finished the examples. We're just about right on time here. Again, these are the ingredients that we've covered today. This is by no means an exhaustive list, but our goal here is to generate your awareness and your motivation to go out in the world and begin to question these things when you're seeing them. We've got some great talks coming up that will talk about the status in the UK and the US, and some great research that we're beginning to understand some indicators of what's happening when we're trying to intervene in society around mental health concerns. So a couple of take-home strategies. I've laid these all out here and I'll just sort of talk through them briefly. First thing is awareness. We are here today to increase people's awareness about the crisis narrative. This is a thing that exists in society. It hasn't always existed. So you need to see it, you need to name it, and you need to question it. It's a little bit like taking the blue pill if you're a fan of the Matrix. You need to become aware of the big picture out there. Details really do matter in this time of rapid news cycles, shallow news cycles. Think critically about the information that's coming across your desk. Think critically about the way you talk about mental health and what we're trying to do to support people. Encourage those around you to do the same. And then think about how can you help to normalize the human experience instead of pathologizing it. Think about the language that you use with people in your community, students, faculty, staff, parents. We really do need to move toward an awareness of what pathologizing the human experience has done and what we can do moving ahead. Number 4, patience. So it took us more than 20 years to get to today in terms of what we experience on a day-to-day basis around this idea of a mental health crisis. This is not going to go away quickly. Social media is not going away. This idea that people use the term mental health to talk about their experience is not going away. So it's going to take time to achieve this change. But if we all engage in this task collectively, from this point forward, we will begin to push it in the right direction. Strategy and not reaction. Implementing and dealing with the mental health crisis and implementing successful mental health services is about having a strategy that's long-term, that is not changing with each time there's a negative event that happens in the world or on campus. Importantly, institutions are responsible for educating students. That's why we're all here. But we often don't, I think, take enough time to educate students about this, the normativeness of the human experience, what human distress looks like, all the ways that people cope and adjust and grow over the course of their lives. And this has to be part of our educational mission. And then as part of that is a population approach to mental health. We cannot realistically route every person with distress through professional treatment systems. Absolutely not possible. It's not tenable, unless we want to fundamentally restructure society, really, and finances of society. So population approaches are about supporting all people with new and evolving support systems that are not just traditional treatment with a professional. So you need to have both a population support strategy and alongside your specialized treatment strategy. And then the final thing that I would say is that we need to seek alignment among your community members. And I've provided a link here to a blog on the alignment model of staffing college and university services. The frank reality is that institutions are different. Some institutions have funding and resources and some don't, and some are in the middle. And that what's key there is bringing people together so that you're on the same page about what you can and can't do in any given institutional setting. And be very clear about the language we're using and what's available and what's not. And so that concludes my portion of today's webinar. And I'm going to check in with the team here, but I believe we're going to be taking a break, Jane. And then when we come back, I will provide your introduction. Does that sound okay?
Yeah, fantastic. Thank you so much. So yeah, we're going to take a short break now. We will be back at 10:02. There are lots of time zones going on, so it's an 8-minute break.
An 8-minute break. All right, we'll see you very soon. And so let me, oh, thank you. We're recording now.
Hey.
It's good to know. All right, so it's my pleasure and honor to introduce the next contingent of speakers, starting with Jane Harris, who's been in the mental health field, student mental health field for 15 years, and is currently the co-director of student welfare and support services and the head of counseling at the University of Oxford. But that's not all. She is also the chair-elect of HUCCCCD, the heads of university counseling services, and it's been a joy to watch HUCCCCD work with AUCCCD. You are also the co-chair of the Mental Wellbeing and Higher Education Group, hosted by Advance HE, and a member of the Department for Education Mental Health Implementation Task Force, and part of the BACP Universities and Colleges Division Executive and Governance Group for Student Space. And more importantly than all of that, you are the reason we're here today. So thank you so much for being the spark that lit today's event, and I'm happy to hand it over to you to take it from here.
Thank you. And thank you, Lucy. So Lucy's going to help me with slides. And in a way, that introduction to sort of my professional biography is a useful starting point about why we're here and why we have organised this event. And I think I want to really emphasise that this event is motivated by our collective commitment to students. I think it's no accident that it's clinical leaders of student services and leaders of student services who have been, I think, the most sort of perplexed and confused and feeling quite uneasy over the last 10 or 15 years. And so the motivation is a kind of a noticing of a growing unease amongst leaders of student services, particularly clinical leaders, that something isn't working. There is something about our current approach that we just feel is missing. And it's not just about staffing and resources, but it's also about how we actually understand the growing numbers of people. And I think it's important to say this isn't just in education, it isn't just students, but people, young people, students who are defined as mentally ill, whether that's by healthcare systems, by society, or by themselves. We're concerned about the impact of that. Ben spoke about contagion, he spoke about identity. We're very interested in if this is the culture you're operating in at the point in life that we would call emerging adulthood, which is all about identity formation, your understanding of yourself and your capabilities, how might that impact your, how you step into your life, particularly as a graduate? So that's why we're here. It's a fundamental commitment that leads us here. Lucy, next slide, please. And I'm going to just repeat something that Ben said, which is the absolute respectful acknowledgement of experience. And I think this is very much a kind of systemic or sociological conversation we're having, but there's a massive risk that it's experienced or heard as a dismissal or a devaluing or a rejection of the reality of somebody's experience, their emotional experience. And so, obviously, again, we're predominantly clinicians on this call. And so that, our motivation for our training and our work is the kind of recognition and how people's suffering moves us. And so this is just to reiterate that we absolutely respect and acknowledge and do not question the reality of people's emotional experience and the need for us to respond with compassion and respect and understanding. Similarly, this in no way questions the need for mental health services. Again, it's our kind of daily work. And it also means, this is not in any way questioning, the importance of addressing systemic inequalities of access and outcomes for the many, many minoritized groups in society who don't have fair access and outcomes with mental health. So I think we just wanted to really say that very explicitly, and we're probably going to repeat it several times, because I think we're aware there's a potential that this could be heard in a way that is not intended, and we're certainly not endorsing some of the very simplistic tropes, such as the snowflake generation. So this really isn't about that line of discourse. Next slide, please, Lucy. I'm going to say a little bit about, part of the origin story of today. It's going to mirror some of what we're hearing from the US and what we're going to hear in a bit more detail from Brett and Marcus. So we know that student requests for mental health and counselling services in higher education have more than doubled, in some cases trebled, over the last 10 to 15 years. I think I estimated I've read about 20,000 student intake forms for counselling, mental health and wellbeing services. And within HUCCS, which is Heads of University Counselling, we have noted, and I think University Mental Health Advisors Network similarly have noted, particularly in the last 7 or 8 years, an increasing prevalence of diagnostic, medicalised language that students are using at the point of self-referral and assessment, which we think is starting to really reflect that kind of reframing of emotional experience. We're also noticing increasing that students really believe that a professional intervention is needed, because if you define your experience as mental illness, you're probably more likely to think things can only change for you if you have a professional intervention. We know that prescription rates for antidepressants, I think, have doubled in the last 10 years for the UK population. And we're seeing more requests for what we would call long-term weekly sessions. And I think Tim, in his opening remarks, noted the really quite shocking reporting that we had in the UK in February and March, that there are now more young people in their 20s who are out of work on the basis of mental ill health than there are in their 40s on the grounds of physical ill health. And yet we know from the World Health Organization that all the social and economic determinants of good mental health include work, education. There are a whole set of things that are actually really important for us to live well. Lucy, next slide, please. Lucy, I wonder if, here we go. I'm not going to linger on this. There's extensive evidence of increasing requests for support, and we've got the same kind of media representations of mental health crisis as you're seeing over the pond. Next slide, please, Lucy. And we looked to the NHS digital data. This used to be the UK Psychiatric Morbidity Report, consistent reporting of increasing difficulties for children and young people. Last year was the first year where NHS Digital reported that rates of increase for possible and probable mental health disorders was now it was now faster amongst children and adolescents and young adults than it was amongst the older adult population. Next slide, please, Lucy. And this is just further data for us to consider. Next slide, please, Lucy. And this report came out, I think it was either last week or the week before. Both Mind and the Centre for Mental Health are excellent charities. They're doing excellent advocacy work. But I just wanted to note that the first words of the foreword to the report are that we're currently in the middle of a mental health crisis, and that the scale and severity of mental health need is spiralling, and many of us aren't getting the help we need. So it's just to note, another incidence of this narrative in very recent history. Next slide, please. And I'm going to take us in a slightly direction just for a few moments, because I want to pause. Ben, you've ended by noting some of the things that we can maybe do differently or start to think about. And I wanted to stop and think, what do we know about the social, the environmental, the relational conditions that foster and facilitate human growth, human development? And because these are the preconditions for how we have good mental health, or how we can endure and survive and tolerate difficulties in our life. So we know that we need a secure base, and we also know that we need to be able to go out and explore from that base. We know that humans are interdependent, and that we need to experience our capacities for both dependency and autonomy and independence, and it's just a kind of dance between the two through life. We know that as people, we need a balance of support and challenge in our lives. Too much of one can be unhelpful. We know that we need to be given and to hold responsibilities over a period of time. This is something that we don't talk about enough, but we also know that there's incredible value in positive risk taking. And there's a lot of clinical evidence now around working with people who are living with thoughts around self-harm and suicide, that, you know, you can lock somebody up and, you know, make them very, very safe, but that doesn't give them a great quality of life, but it also actually reduces their capacity to tolerate and manage, you know, the feelings that they're living with. And I think we're not talking about this enough. The next slide, please, Lucy. We also know, and I think, again, Ben, you've mentioned this, that experiencing a full spectrum of emotions is developmentally essential. It's valuable. Yeah, we need to have a full emotional range in our daily lives, and that does include some of the more difficult emotional experiences. We also know that there is great value in what you might call a purposeful pause or a watchful waiting at times of distress. And this, again, links back to something, Ben, you said about timeframes and how we don't overreact or react too quickly. We also need to stop assuming that people are going to be harmed or traumatized after a difficult experience, and we need to start talking about the potential for harm. And we need to think about short, medium and long-term perspectives. And I think finally, for those of us who are thinking about the proportions of our student populations who are the kind of school-leaving young adults, we need to recommend that the developmental task of late adolescence and early adulthood is one of separation and individuation, and the conditions we create within higher education must allow for that process to happen. Next slide, please. So I'm going to bring us back slightly, because I've segued off to think about the conditions that create good mental health and that allow for human development and growth. And I'm going to come back to the question of what we're here to do today. And we're here to ask some really quite difficult questions. And we're also here to think about what we maybe think we know, but might need to understand differently, and also what we don't know. And so the causality around mental distress is incredibly complicated. There's a kind of biopsychosocial model, and even there, you know, we don't have an absolute understanding. But what I'm interested in is, you know, is how we develop the evidence base for our policies and our practices and our interventions, both with individuals, groups and communities. And something about what is it we're trying, I think, Ben, you made this point, where are we trying to get to with this? You know, what is our notion? What is the possibly the unspoken or the even unthought ideal, which is it cure? What does that mean? What is the state we're actually trying to achieve? And I'm interested in how the crisis narrative might impact our ability to engender those conditions that actually foster growth and development, and what is the interaction between these two things. Tim, you mentioned paternalism in policy and practice. I'm interested in what are the conscious and the less conscious messages that are being communicated, the more we try to protect. You know, what is it we're actually saying? And are we communicating a lack of confidence or a lack of belief in somebody's capacity to be autonomous at times? Next slide, please, Lucy. I'm nearly at the end. And so today has been a year in the making. We've been having, you know, regular conversations with our colleagues at AUCCCD and with Ben at Togetherall and with Advanced HE. And we're really here to explore and engage. We really want to engage you, and I'd encourage you to feed back to us in the chat how this is landing with you, what it might provoke in you, the bits you don't agree with, the bits you think that might be of interest, anything you're thinking that we haven't mentioned. And we just to recognise there is uncertainty within this process. And by that we mean we have got so far in our thinking, but there is a lot further we need to go. We certainly don't have all the answers. And I also want to recognise it takes courage to be quite open to this respectful re-examination. And I think it's really hard for us to consider that there may be inadvertent harm in aspects of our current approach. But looping back to the reason why we're hosting this event and the series of events is we're increasingly actually quite concerned that what we're doing is inadvertently causing harm to the long-term psychological health and well-being of a whole generation of young people. I suspect there's a lot more to understand, but I think that is what we're here to think about. And it's not an easy thing to think about. And I think, you know, we're all very conscious of the potential for this to be misrepresented, misunderstood, and for somehow it to be perceived as criticism. So Ben has spoken to us about, he's introduced us to some of these new lenses. So we're here today to really introduce you to some of the different ways to think about this. So Ben's spoken to the 6 ingredients. Lucy Fuchs will be presenting an overview of her research, and then we have the event in March, which is our first main event, which will include Nick Haslam from Australia speaking about concept creep and the psychiatrization of everyday life. So we have a few other speakers, so we're not going to share all the amazing stuff we have today. Next slide, please, Lucy. Okay, I think this is my summary. So today we're inviting you to step back and from a position of compassionate and respectful inquiry and applying a sociological or a systemic lens to consider the relationship between how we understand and talk about our emotional and psychological experiences and how this may then shape how we subsequently experience our emotions, our psychology, our mental health, our mental illness, both individually and collectively. And then to ask if the actions that are motivated by our desire to mitigate and relieve distress in the short term may be inadvertently undermining long-term development and growth and actually diminishing the capacity to find value, purpose and meaning through love and work. And I've used that very purposefully. Those of you who know Freud will know that Freud said that, the goal of therapy was to have the capacity to love and work. And I think there was something about misery as well in there. So I think that's the end of my slides. I am very, very pleased to introduce Marcus. Now, something we haven't spoken to extensively today is just how important it is that we have representation from, well, I'm going to actually say, Marcus, I'll say who you are. So Marcus Hottling has been the Counselling Centre Director at Union College in New York State for 17 years. And he was president of the Association for University and College Counselling Centre Directors, that's the AUCCCD, for the last 3 years. AUCCCD is a professional organisation with 900 member institutions, predominantly from the US. And it focuses on the development and the support of clinical directors and the work of clinical counselling services and mental health services in American higher education. So they are a very significant voice in the sector. And then I think Marcus will tell you a bit about Brett. And I think it's really important to note the level of commitment to this conversation that we have transatlantically. Okay, Marcus, over to you.
Thank you, Jane. And good morning or good afternoon, depending on your time zone. I do think that it's very important to recognize that this is just the first hour and laying the groundwork, or 2 hours and laying the groundwork for a much larger discussion that needs to happen. Because ultimately, all of our students are kind of dealing with the exact same thing, maybe for different reasons. And I'm going to talk very briefly because I want to leave time for my colleague Brett to kind of go into more of the data. And I don't want to kind of restate what Ben has already stated, but I do think that it's important to kind of recognize what we're seeing here in the United States and some of the reasons why we're seeing it. If we go back 20 years, and Ben kind of talked about this, that's when the alleged crisis actually started, when we started to see significant increases in utilization, significant increases in people coming into counseling centers due to a reduction in stigma, a better understanding around mental health, and billions of dollars being spent on trying to do that. We flattened out. Utilization flattened out prior to the pandemic and actually has decreased in the United States post-pandemic. Now, that's a false decrease because with the acceptance of telehealth, more and more students are utilizing their clinicians from home. So I'm not saying it's an increase, but it's a false decrease. What we're really seeing, however, is the inability for our students to sit with any sort of discomfort. And thus, everything to them has become a crisis. And we also have to look at why that is. And part of that is the parents and is the administration and are the adults in the room. In the United States, we have lots of complaints about participation trophies. You get an award just for participating. You get a ribbon, you get something just because you signed up and you participated in it. But one of the things I always try to point out is who is handing out those participation trophies? It's not the students and it's not the kids in Little League or any sports, it's the parents. And when we see that a parent really trying to prevent their child from learning from failure and learning from discomfort, that's why we have the verbiage of everything being a crisis. Ben talked about this as well, but social media, news, everything is now being framed in a mental health way. When somebody is feeling down, when somebody is crying because they didn't do well on a test, it's because they're depressed and they need counseling. No, it's because they didn't do well on the test and they're upset. That is okay. So we really need to kind of do some education, and we need to educate the community and the public, not to diagnose everything in mental health terms and to look at it for what it actually is. And this really needs to start at the national level. If you look at the past 2 years in the United States, President Biden, in his State of the Union last January, indicated there's a mental health crisis in the United States. Now, he indicated this, and it was to give money towards mental health treatment, which is wonderful. But when you're saying this to a national audience, that's a problem. Same thing with the vice presidential debate in this past election. J.D. Vance said there is a crisis, a mental health crisis in the United States. Crisis is just an easy word to use. Again, I'm parroting Ben here, but we have 24-hour news coverage, as does the rest of the world. However, we like to talk in sound bites. We like to talk in snippets, and we really don't want to explain to people what the mental health situation actually is. So I'm going to end and pass over to Brett, but the one thing I do want to say is that it is really important to utilize the national organizations and the people around you. You know, my one voice is just one voice. And I think that it's really important for us to get behind this on an organizational level, on a government level, on national levels, if we're going to make changes in this. Because Ben can preach it to the world, Jane can preach it to the world, Brett can preach it to the world, I can preach it to the world, but one voice is only going to have so much of volume versus hundreds and thousands of voices that can get together and really kind of push the narrative from crisis to what it truly is. So with that, I'm going to end, and I'm going to pass over to Brett, and I'm just going to do a quick introduction to Brett. Dr. Brett Schofield currently serves as the Associate Director of the Penn State Center for Counseling and Psychological Services, as well as the Executive Director of the Center for Collegiate Mental Health, CCMH. CCMH is a national research center that includes a network of over 800 college counseling centers. Dr. Schofield has played a significant role within CCMH for the past 10 years, contributing to numerous publications on the topic of student mental health and helping the center develop several tools that are widely used by college counseling centers nationally to advocate for services. With that, I'm going to pass it over to Brett. Brett, your slides are good to go.
And thank you, Marcus. Can you hear me okay? All right, great. It's really an honor to be here. Thanks, Marcus, for that introduction. Really pleased to be here to talk at the symposium about the work of CCMH. I have several slides I want to show you. Just a brief history about CCMH. CCMH was founded in 2004 by Dr. Ben Locke, who you just heard from. Really, the foundation of CCMH was to build a database, a standardized database that can inform the narrative about what's happening in collegiate mental health nationally. Because back 20 plus years ago, policies and the narrative was informed by just anecdotes and also just extreme stories. So Dr. Ben Locke thought about a way that we can collect data from students when they enter services at college counseling centers nationally. We're not doing surveys, we're actually collecting data from clinical tools. And we have grown over the years to collecting data from students at 800 centers. And we also collect data from therapists. We have over 7,700 therapists who are estimated to be in our network. And our tools and research are estimated to affect over 660,000 students in care nationally. What I'm going to show you is some of our updated trends that are going to be released in a couple months. And this goes to the most recent year data. Again, this is all from clinical students, from the clinical population. So it's students who are receiving counseling center services nationally. This is from our self-reported distress instrument called the CCAPS, the Counseling Center Assessment of Psychological Symptoms. These are the common areas of distress. And you can see these are what are called spark or trend lines for the last 14 years. All these lines are relative to each other. And you can see here that there is some upward trend over the course of 14 years, but there's been a relative flattening out of some of the major areas of symptoms, including depression, generalized anxiety, and social anxiety. One thing that probably will catch your eye is this really marked increase in academic distress during the onset of COVID and online learning, and that has since kind of receded a bit, but it's still above pre-COVID levels. But in the last year here, we were really seeing a decline or even a flattening of some of the areas of distress. The area of self-reported distress that has increased the most in the last 14 years is social anxiety. I'm going to switch to mental health history items that are reported by students. These are threat to self characteristics. Again, these are things like history of non-suicidal self-injury, serious suicidal ideation, suicide attempts. You can see here some slight upward trend in this before COVID, but since the onset of COVID, there's been an abrupt decline in some of these symptoms, and then a gradual kind of upward trend since, but we're actually at below COVID levels in terms of students who are coming in on average with histories of threat to self characteristics. History of trauma. This is an area where we have seen an increase over the last 12 years. About 46% of students are coming in saying they've had some kind of history of trauma. That has been going up, but in the past year, it actually went down. And it went down on general trauma as well as experience of harassing and controlling behavior and sexual assaults. Prior treatment. This is an area of mental health history that we've actually seen an increase. So students are increasingly coming in and telling us they've had a prior outpatient treatment history in counseling and medication. We're at a high watermark on both. So about 64% of students are coming in with a history of counseling, and about 40% of students are coming in with a history of taking a psychotropic medication. In terms of histories of having a hospitalization for a psychiatric reason, we've been flat over the last 12 years at about 10%. When you ask the therapist, so that is all the students self-report. Now I'm going to show you a slide that's telling us what therapists are assessing when students come in for treatment. These are also relatively flat. The three most common concerns that therapists assess when students are in their offices are depression, anxiety, and stress. And anxiety has, over an 11-year period here, has gone up, but it has been flat for pretty much the past 5 years. But it is the most common concern. So about 2/3 of students come in with anxiety. The second most common concern is stress, and depression is the third. Depression has actually been on a slightly downward trend since 2017. Other areas that are commonly assessed are trauma, suicidality, which is at about 10%, as Ben mentioned. You can see here the trend line for trauma. It corroborates what students are telling us, although at a lower rate, that therapists are increasingly telling us that students are coming in their offices with history of trauma that need treatment, although that is also flat the last year. I'm going to speak to what Marcus talked about with changes in counseling center utilization. Utilization being the demand. How many students are actually coming into your service, into your center for services? I'm going to give you a look at the general student body and counseling center services that are utilized. And I'm using CCMH data here, and I'm using the Healthy Mind Study data. So I'm going back to 2017-18. So this is 3 years before the onset of COVID-19. Our best data that we had nationally was about 27% of students received some kind of mental health care in the last year. That could be from their medical doctor, that could be from the counseling center, it could be from their therapist in the community, about 27%. And about 12.5% were counseling center specific clients. And so that meant that gap was about 14.5%. So the gap was about 14.5% of students who use mental health services outside of the counseling center. Let me show you how that shifted now in the last year, after 3 years after COVID. You can see here the demand in the general student body has actually increased a bit, but counseling centers' share of that percentage has gone down. So it's speaking exactly to what Marcus said, is that students, the demand is not necessarily going down in the larger student body, but students have so many options for care now that the care is becoming more fragmented. Students have more options with teleservices, staying in treatment with their therapist from home, who now can do Zoom-based counseling, where before they could not. So this has implications for higher ed. Another look at this too is it shows you the distribution of centers from 2018 to 2024 who have increased their utilization, who have really stayed about the same, and who have decreased. The overwhelming majority of counseling centers, about 2/3, have shown some kind of decrease in demand. And about 18.5% have remained about the same, and about 13% have increased. This is really important because this is also talked about in the narratives of media about increasing demand and it being out of control. It's really a nuanced, though, discussion, because that is true, but counseling centers actually on average have shown a decline in utilization. The flip side of that is up here, is that because we have seen a decline in utilization and our caseloads have gone down, we've actually been able to provide more treatment to centers. So getting the narrative wrong on this can have implications, because students who really need care might be deterred from reaching out if they think systems are overwhelmed, or that they're not going to get this advantageous, beneficial increase in care. The last thing I want to just talk about regarding just our thinking about things is I'm going to talk about student success and multi-layered support options. Student success is really important for us to focus on, and how our collective services enhance or correlated with student success. Student success I'm defining as whether students persist in school or whether they even ultimately graduate. And it's really important to focus on multi-layered support systems. My colleague, Natalie Hernandez, calls it equifinality, which means there's multiple pathways to achieve the same result. And we can do that in mental health as well. Primary prevention in higher ed right now, some of the more advanced systems are focusing on these multi-layered support options. And primary prevention being the types of interventions that prevent problems from occurring before, problems from happening before they occur, right? So things like institutional wellness initiatives, wellness platforms, peer support programs. These are things that can really enhance primary support missions. And then secondary prevention is when symptoms have early onset. These are things like consultation programs. We call them Let's Talk programs in the United States, coaching services and self-help platforms. And tertiary care is where is the counseling clinical services that people generally think of going to when they need help with their distress. Those are our group counseling and crisis care services. But there's multiple different support options that can help students that we need to think about that go beyond clinical care. If counseling centers are feeling overwhelmed because institutions are pushing everything down towards tertiary care, prevention or intervention, then counseling centers can get overwhelmed if they don't go upstream and focus on some of the more secondary and primary prevention. Really, with student success, we have to think about how these collective services benefit students in terms of letting them persist in school and actually ultimately graduating. And the questions we're trying to answer is a very nuanced one, is who needs these support services? What specific support services do they need? And importantly, when they need them. We know that first year of college is the most critical year where students might need more enhanced support in order to help them persist in school. We know from our own research that if you provide an intervention that helps students decrease their distress symptoms while simultaneously engaging in some kind of extracurricular activity, they're more likely to persist in school. And that ends my portion here, and I'm going to turn back to Jane.
Hello, I'm here. Thank you. It is so interesting. I think we're all slightly envious of the data sets that you have in the US. You know, it's phenomenal, that sort of 660,000, I can't remember the figure, it was enormous, the data you're drawing on. So thank you to Marcus and Brett for the view from the States. And I'm now going to introduce an Oxford colleague, Lucy Folks. Lucy is a Prudence Trust Research Fellow at the Department of Psychology in Oxford. And she has a research interest around adolescent mental health. Her book, What Mental Illness Really Is, has been incredibly well received. And certainly we're working with Lucy in our department on some research projects. So Lucy, really pleased to have you here. And I'm just going to hand over to you to say a bit about the work you've been doing.
Hi, thanks so much, Jane. And hi, everyone. Hopefully you're still with us, even though I can't see any of you. I'm conscious that some of what I'm going to talk about today is going to overlap a bit with what's already been said, but hopefully that will just reiterate that lots of people are interested in this problem. And I also want to make the point that I'm not a clinician, and I'm definitely coming at this problem as an academic, trying to figure out how we get, how we empirically test what a lot of people are concerned about, and a lot of people are talking about and kind of assume to be true, but it's actually quite difficult to test. So I'm going to give you a brief taste today. I can't even cover everything I want to talk about when I'm given an hour, so I will try my best to convey what is most important ahead of more detail in March. I think I'm, sharing the right screen, so I will go ahead. So I'm going to talk briefly about some of the work I've been doing, primarily theoretical, but starting to collect some empirical evidence about what I see as the problem with mental health awareness. If you're not familiar, this badge, amongst other things, can be bought on Etsy. As part of a kind of whole raft of what I would call merchandise related to mental health. And I think in some respects, this could be seen as a good thing to wear a badge like this, maybe if it was a non-verbal autistic person. But I think this actually signals something else, something a bit more complicated and problematic about kind of how far we've come and possibly how we've overshot when it comes to mental health awareness. So this kind of preamble you will be familiar with if you're in this webinar, but I became interested maybe 5 years ago about the shift in mental health discourse in society that I saw as kind of being initiated by these mental health awareness campaigns. And this wasn't the very first one, but this is a big one in the UK in 2011. So it was rolled out on TV and on billboards, etc., by Time to Change. And this was their kind of flagship stat. So they were really keen to make the point that to encourage people to realise or believe that mental health problems are more common than might have previously been thought. And from there, there's been a whole host of campaigns and initiatives. So some encouraging people to look out for their friends and think about their friends' mental health. Some focus specifically on children's mental health. Some obviously relevant for this call, focused on university mental health. Students are bombarded with information about their mental health, obviously mental health in the workplace. This is an NHS campaign a couple of years ago, where some minor celebrities spoke the words "to help" by the Beatles and encouraged people to access help via the NHS. But they can all these initiatives can really be summed up with this message. So however you do it, start a conversation about mental health. So the assumption is that the more you talk about mental health, the better. And the only problem really is that we're not talking about it enough. So about 5 years ago, when I was starting to write the book that Jane mentioned, I started to become a little bit wary about whether all this messaging was straightforwardly a good thing. So whether it was universally a good thing to encourage particularly young people to notice, label, seek help for, seek adjustments for, talk about essentially any negative psychological experiences, which are either explicit in these campaigns or that's kind of the message that you end up receiving, that basically negative psychological experiences equals mental health problems and we should talk about it and seek help for it. So I'm becoming increasingly convinced that this has had unintended problematic consequences. I don't think it's been straightforwardly bad. I think there are lots of people who will have benefited from this, but I think we urgently need to have a conversation about whether well-intended ideas have gone awry and caused some unintended effects. So you will all be well versed in this, but I'm interested in the idea that mental health problems obviously exist on a spectrum, and whether the language and the interventions and the adjustments that really should be reserved for people, don't know why that's moving, up at the red end has kind of leaked down into the rest of the spectrum. So when I have longer, I talk in more detail about the fact that this spectrum is not a binary, but it's really, really, really important when we're talking about the topic we're talking about today to not fall into the trap of saying there are people with serious mental illnesses and other people who are misinterpreting common stress and regular life experiences. There are those two groups, but I think that the reason why this has become so messy is because there are 1,000 variations within those two groups, and it is not easy to draw a line and say that person has a diagnosable mental illness and that person is just unnecessarily stressing about their exam. There's an awful lot of grey in the middle. We need to constantly hold that in mind when we think about how we address all of this, because there is no solution we can offer where we say, do this with the people with mental illnesses and do this with everyone else who's fine. It's much, much more complicated than that. And I think the existence of this spectrum is actually why we've got ourselves into this mess, because it's all the people in the middle that often we can't quite figure out what help they need, what interventions they have, what we should call their problems, what they should call, refer to their own problems. So I just want to highlight that complexity. But nonetheless, I'm absolutely not the first person to observe this idea that the language and terminology that was once reserved for the most unwell minority is now being used much more liberally. This is a particularly nice paper about it, which describes the psychiatrization of society. Nick Haslam's work on concept creep is also very relevant, which I normally mention in longer talks, but he is speaking in March, so you can hear it from the man himself. But I'm absolutely not the first person to observe that this is happening. The people who are receiving these messages about mental health are not just receiving them from formal outlets like schools or charities. They're also receiving it online. So we've had brief mention of this already. But if you are not on TikTok, there is a particularly popular type of video on TikTok, which says essentially, here are 5 signs of a mental health problem that you didn't realize that you had. And then it describes 5 pretty generic, universal psychological experiences, almost things like being a people pleaser or fidgeting. And this first person, who is a who is a clinician, the person on the left, saying the last one I see the most, that is an intentional strategy to make people stay on the video right until the end, because then that means her video will be be more likely to be shown to other users and therefore get more attention. So these videos are intentionally picking quite generic common symptoms and actively encouraging people to interpret them as mental health problems. I've now got a video which takes a related idea but with trauma. If it doesn't work, it doesn't work, but I'm going to give it a go and hope that you can hear it.
I'm a licensed therapist, and this is the test to tell if you have trauma. Now, if you're going to do this with me, you need to stick around to the end. If you're not quite ready to do this, that's okay. You can come back later. Or if you just want to learn something, that's fine too. There are millions of people asking the question, have I experienced trauma? It's such a puzzling and confusing question, and people just don't know how to truly answer it. I really want to make this clear for hopefully many people. This is the trauma test, okay? And I really need you to take a moment to consider this, okay? Are you hurting? The answer is yes, you have trauma. Trauma comes from the Greek word traumaticus, which means to be hurt. And if you are hurting, you have trauma. And don't you ever let someone tell you that you don't. Now, there's someone sitting and suffering alone in silence and darkness, and your likes and shares could literally light up their life.
That end is your likes and shares of this video could light up their life. So I think there's actually something quite sinister about what this person is saying, not only encouraging you to interpret anything painful as trauma, but that you should not allow anyone to question that narrative. So I use these examples here just to make the point that young people in particular are being bombarded with this information that they should interpret their experiences in this kind of psychiatric way. We've heard today, lots of other people have observed this as well. What gets more complicated now, and what the field of academic psychology is still only really just starting, is about how we test and demonstrate what this is actually really doing. Because lots of people can say this is probably doing something bad, but it's another thing to then actually start to demonstrate that. So I'm going to give you a little taste of what I've started to do in my lab, and hopefully by March I will have some more information
Licensed
for
therapist.
you. So last year, my colleague Jack and I wrote this paper. So we presented this hypothesis that mental health awareness efforts might be contributing to the rise in mental health problems that people are reporting, particularly in adolescents. So I'm going to describe this hypothesis to you in detail in a minute, but I just want to really stress that we have certainly don't think this is the only explanation. So it's absolutely true that many more people are now reporting mental health problems than they used to, even in the fairly recent past. Sometimes my work is kind of pitted against the alternative explanation that this is a real rise and that it's happening because of, you know, social media or COVID or increased academic pressure or whatever. I don't think they need to be in battle with each other. I think if mental health awareness efforts are a contributing factor, they may well be one factor amongst many. So it's not like you have to pick that it's this or that it's a legitimate rise. I think multiple things can be happening at once. So this is the hypothesis that we laid out. So this is the kind of boring bit that we suggested, that as more people report symptoms, more official bodies, schools, universities, governments, the NHS will disseminate information and materials to try and raise awareness about identifying these problems within themselves and seeking help. So that makes total sense. What Jack and I were interested in is suggesting that this might be a bi-directional relationship. So the more awareness efforts that we pump out into the world, the more people end up reporting mental health problems. I mean, this is all just an idea, and we're now moving on to try and test this. But at this point, it was a hypothesis. And we suggested that this bottom route was happening via two mechanisms. So the first we called improved recognition, and it's kind of unexciting in a way, but I think it gets forgotten. It's really, really important that if you accurately improve awareness, raise mental health literacy, teach people what mental health problems are, reduce stigma, you're going to get people identifying problems that in previous generations went underreported. So that doesn't mean the problem's getting worse, but it does mean that people are going to report high levels of symptoms to their doctor or even on anonymous questionnaires. So this is actually a good thing. This was the whole point of those, a lot of these campaigns, was to help improve recognition of previously underreported problems. But the second route is what I guess we're more interested in, and certainly the people who've been interested in this paper are more interested in that route. This paper's had a massive amount of interest, particularly media interest, international media interest. Lots and lots and lots of people are concerned about this as a problem. So with this second route, we are proposing that the more you teach people about mental health, at least some of them will start misinterpreting milder symptoms as being symptomatic of a disorder or a mental health problem. So, for example, if you get, I mean, there's no such thing, but if you had two people that were like a 3 out of 10 on an objective measure of anxiety, and the person in the past might have said they were 3 out of 10, and now the person with that same objective level of anxiety is now reporting that they're a 5 out of 10 because they've become so kind of hyper vigilant to these possible problems. So that was one route that we suggest. And then we also wondered whether that in itself could become a self-fulfilling prophecy. So once people interpret their problems as a mental disorder, they can actually end up bringing those symptoms into being. And I always use the example of anxiety here. So if you interpret your anxiety as anxiety, the disorder, you will change the way you understand yourself. You'll start saying, I have anxiety, and you will change the way you behave. So you might be less inclined to do the things that make you anxious. But we all know on this call that, you know, avoidance can maintain and exacerbate anxiety. So this was this kind of extra offshoot of the hypothesis that we thought not only are people misinterpreting their symptoms, but then that misinterpretation might then become a kind of self-fulfilling prophecy. I also mentioned Isaac Ahuvia's paper here because he wrote a kind of update to this paper saying that that's a more distinct hypothesis than we had originally said, which I think is fair. So this is very much just an idea at the moment, but as I said, it generated a lot of interest because a lot of people intuitively felt it could be true or were worried that it might be true themselves. So before I talk about possible evidence, I want to stress that this isn't a new idea. So it's a very basic psychological concept about expectancy effects, that if you tell people that they're likely to experience something, they then become more likely to report and possibly actually experience that thing. So I mentioned here the nocebo effect, which is like the kind of evil twin of the placebo effect, which is when people develop side effects or symptoms that can occur with a drug or therapy just because the patient believes they may occur. So if you tell people about side effects, they end up reporting them even in the placebo group. So this has most often been found with physical symptoms, but it's also been found with anxiety. So this is not, we should not be surprised at the possibility that telling repeatedly a generation that they might be vulnerable to mental health problems could lead them to report more of those problems or actually experience more of them. So what's the evidence? It's all limited at the moment, but we're starting to build an evidence base. So in March, I'll have much more to tell you. But we're writing a review in my group at the moment for Nature Reviews Psychology, where we bring together some experimental evidence that tests some element of what mental health awareness materials are doing. So experimental evidence, specifically the idea that you bring people into a lab or you do these tests online, you manipulate something, so you show them different groups of people, different information, for example, and then you test what the outcome is or what the difference between these two groups are. So I'm going to give you a quick run through of what we found so far. So this, I think, is one of the most important papers in the review. This study found that a group of people who read social media post that normalizes anxiety are subsequently more likely to report that they might have an anxiety disorder, but it doesn't increase the level of symptoms that they report. So there's something about, if you read this message that anxiety is normal and common relative to it being rare, you are more likely to experience an equivalent level of anxiety symptoms as possibly being symptomatic of a disorder. Similarly, this study found that if a group of people who read a broad definition of what trauma was, then they watched a violent film, that group were then more likely to report that they thought the film was a trauma relative to a group of people who'd read a more narrow, strict definition of trauma. But it didn't change the supposed PTSD symptoms they had in response to watching the film. Similarly, another study found that reading a newspaper article that said food addiction is real relative to a group that read something that said it wasn't real, would then that first group were then more likely to self-diagnose that they might have this thing called food addiction, but it didn't change their self-reported symptoms. Lastly, this is Dasha Sandra's study. That's data's being collected right now, but she's told me that this is what they found, that a group who read some information about possible signs of undiagnosed ADHD relative to a control group, that the first group are then more likely to say that they might have ADHD, but it didn't increase their self-reported symptoms. So we're gaining a little bit of evidence that reading messages about mental health might change the way people conceptualize what is happening to them, even if it doesn't change how they are reporting their symptoms in the moment. Bear in mind, this is happening in like a 5-minute experimental setting. And already it seems to be doing something to how people perceive themselves. I'm going to skip that in the interests of time, because I want to emphasize what I just said about the briefness of what they are seeing, and the fact that in reality, in real life, people are seeing multiple examples of mental health awareness materials every week, possibly every day, and have done for years. And many more people are now starting to look in much more detail at people's TikTok data and seeing how that relates to how they understand themselves. We don't yet have data about this idea of whether things are self-fulfilling, because we'll need to track people over time, but some academics are starting to do that. So there's like 5 people in the world working on this, and 2 of them are called Isaac. Isaac Winterburn in my group is looking at this. Isaac Ahuvier in the States is looking at this, and Dasha Sandra in Canada is looking at this. I'm conscious that I'm at 20 minutes, and I was going to talk about school interventions. Can I go over by a few minutes?
Yes, we have a bit of space in the programme.
Great. Okay, so I want to talk briefly about another kind of strand of my work, which is looking at school interventions. So this is another possible clue, some empirical evidence indicating that all this discussion about what mental health awareness materials are doing might actually be kind of grounded in some evidence. So a couple of years ago, last year, Agiris and I wrote this paper reflecting on the possibility that school mental health interventions might cause iatrogenic harm, i.e. what happens when treatment that's intended to improve something accidentally ends up causing harm or making things worse. I'm specifically, so obviously I know you guys are working in the university setting, and this hasn't been looked at in this context, but I think this is very relevant, what's happening in schools. So I'm speaking specifically here about group school mental health interventions, particularly universal interventions. So this is in these interventions, someone teaches the whole class some information about mental health, general psychoeducation, mental health literacy, but also some therapeutic techniques, particularly based in CBT or mindfulness. We wanted to understand how common the problem was that sometimes people got worse instead of getting better. So when Agiris and I wrote this paper, there was a couple of papers that had just come out showing that in the intervention group, mental health got worse, and in the control group, it stayed the same. So the intervention, CBT or mindfulness, or one example of DBT that was intended to improve adolescents' mental health, actually ended up making people report worse symptoms. With Carolina Guzman-Holst, we wanted to find out how common this was. So we looked at we reviewed all school-based group interventions that taught CBT or mindfulness en masse. We found that 10 out of 112 interventions found one negative effect. So they either made mental health symptoms worse, or pro-social behavior worse, or parental relationships. When I saw this, I was like, maybe that's not too bad. 9% is not too bad. But when we looked at specifically the trials that were high quality, so that they had big sample sizes, decent statistical approaches, it was a third. So a third of these studies found that in at least one outcome, people were unexpectedly getting worse. Why is this happening? I don't know. One possibility is that it's the stuff we laid out in the prevalence inflation hypothesis. Another possibility, related possibility, is that just making people think about mental health makes them feel worse. So this is an excellent quote that I often wheel out from a 15-year-old girl who had a CBT-based intervention at school. It's like you start thinking like that you have low thoughts because the teachers, bring it up all the time, negative thoughts, and that you should change that all the time. But those who sort of have positive thoughts, they start thinking negative in the end. I think qualitative work is extremely valuable for understanding what teenagers think about mental health interventions in schools. I think an example like this can tell us an awful lot about what can sometimes happen when you intended to do something good, but it actually has unintended consequences. So if you're interested in that work, I talk in much more detail about it in this paper. I think anyone running a mental health intervention in any context should be much more alert to the possibility that sometimes it makes things worse and not better. So I'm going to return to this and think about why all this matters. So what I talk publicly about and in my work a lot is really about this idea of people up at the green or yellow end who are suffering or struggling in some way, but shouldn't be framing their problems as a mental disorder. But actually, really, I got interested in this because of people up at the red end and what all of this means for them. So because these people were the original target for these awareness campaigns, it was those people we were trying to help. And I worry that inadvertently, they are now left out of the conversation more than ever. So there is now growing skepticism already towards anyone who's self-labeling with a mental health problem. So this is an analysis we did of attitudes on Reddit. Some people there's a lot of vitriol towards people who self-diagnose. Some people think that self-diagnosis is inaccurate by default, or that people are doing it for attention or to try and be cool. There's another analysis from Reddit within teenagers talking amongst themselves, being very aggressive and angry towards their peers who they believe are faking depression. There is another subreddit specifically called Fake Disorder Cringe, where people share examples of what they perceive as people faking, saying that they have a mental disorder. So there's this massive skepticism now towards essentially anyone who tries putting their hand up and says, I have a mental disorder. You get some people who have been diagnosed now showing what Rhiannon and Lane called diagnostic possessiveness, because they feel like the language has been taken away from them and they want to understandably maintain its boundaries and its value for themselves. And then we'll hear much more from Nick in March, but he has demonstrated experimentally that when you give people broader definitions of these problems, like trauma, bullying, mental illness, people then take them less seriously. I'm going to skip that bit in the interest of time and end on what I think we need to do about all this. I'm often asked, I really don't know. I think we need to press pause and have events like this, which means we're reflecting on what all this means, and stop thinking that more is necessarily better, or that doing something is necessarily better than doing nothing, or that doing something that on paper seems like a good idea will definitely be doing what we hope it's doing. I think we need much more evidence for all of this. I think potentially in this group, in this call, we are collectively sitting on an awful lot of data from services that could help us provide some empirical evidence for some of these phenomena, even just like documenting the language change that young people are using. So we need to move forwards to providing much more evidence for all these theoretical ideas that a lot of us intuitively feel must be happening, but we haven't really moved far enough beyond the discussion or the theorizing point. So I'm going to say thank you now. Sorry for overrunning. Those are all the people who are helping me and leading these projects. Thank you to my funders for helping me conduct this sensitive research. I run a special interest group. We meet once a month and have a chat about all this. Everyone is very welcome to join. I have clinicians and academics and school staff. And that's a more detailed version of what I thought a few years ago about this, which is broadly still the same. So sorry for going over, and thank you.
Thanks very much, Lucy. On to me, Juliet Morgan from Advance HE, just to bring this webinar to a close. And so as I conclude with you today, I want to reflect really briefly on the significance of the conversation that we've started today. Mental health issues amongst young people are rising. In the UK, 1 in 4 students we know report diagnosable mental health condition. In the US, we've heard that over 40% of students experience depression and nearly 37% report severe anxiety. These figures do represent real individuals whose experiences demand thoughtful and informed response. Today's webinar has highlighted critical questions about how we understand and address these challenges. We've explored the parallel trends in the UK and the US, recognising the value of collaboration, and we've examined the 6 ingredients of the crisis narrative and reflected on the implications of Lucy's prevalence inflation hypothesis, which challenges us to think critically about how we interpret and use mental health data. The discussion about language's evolving role in shaping perceptions of mental health has been particularly striking today. Our words do matter, and the ways we define mental health and well-being influence both how we view challenge and how we approach solution. Importantly, we've contextualised these issues within a duty of care debate, asking how universities and practitioners can responsibly support our students whilst empowering them to build resilience. And as our roles blur within institutions, the distinction between student demand and student need remains a vital area for exploration. Higher education does play a critical role in supporting students through their journey of individuation and separation, providing space for growth and resilience. However, the challenges we face by students today are exacerbated by social inequality, trauma, neurodivergence, and limited access to statutory service. And this requires us to rethink how we support them effectively, particularly given tightened budget and blurred boundary. Today's discussion is a starting point and not an end point, and the questions we've raised about boundaries of care, systematic inequality, and how we utilise existing data will shape the future of our work. I encourage you as we move forward to clarify the questions, identify the gaps in the knowledge, test assumptions and explore alternate frameworks, and importantly, to continue the conversation and collaborate on solutions as we move ahead. Therefore, we are all encouraging you to join our symposium on the 25th of March, 2025. The QR code, the details, there you can see on the screen, and the QR code will take you to more information. And to share your thoughts through a feedback form survey, which will come out to you as a delegate of today after the event tomorrow morning. This feedback and that conversation will be invaluable for shaping future events. In closing, I'd like us to remember that we do hold a unique responsibility, both as a practitioner and an educator. Education is not just about academic achievement. It's about the creation of space where individuals grow and thrive. And by fostering critical inquiry, respecting our lived experience and working collaboratively, we can help ensure that both through practice and education, our universities meet the complex mental health challenge of today. Thanks very much for attending. And as we go forward into March next year, I'd like you to think about and reflect on these 2 questions and bring those responses to our event in March. And we very much look forward to seeing you all in the new year. Thank you very much.